Hey guys, this is Ricky Sahu back again. We have Don Rucker on the line. So Don Rucker is the national coordinator of the ONC, and he will be talking to us about some of the new rules that the ONC just released this week. So without further ado, Don, I'm going to kick it off to you.
Okay. Thanks, Ricky. We set to go?
Yep, we're ready to go. Thank you.
Okay, great. Well, welcome everybody. I'm sorry that we didn't get to do this live, but I think it's a tribute to technology and interoperability that we can do this virtually. So obviously the big news from HHS here in terms of interoperability is that we and CMS released interoperability rules on Monday that I think folks have probably heard a lot about. I believe you heard about the CMS rule earlier today. So the ONC interoperability rule is implementing what Congress asked us to do in the 21st Century Cures Act. So if we go back to what Congress asked, and that law, I should say, was passed almost unanimously by Congress, so really a very bipartisan piece of legislation. In the Cures Act, there were two big requirements for interoperability that we have now implemented in our rule. And I think if you think of it that way, as you're potentially looking at the rule, we're going to have educational sessions, I believe later today, tomorrow, in the weeks that come. We have at our healthit.gov website all kinds of information. But if you think about the two big things that Congress wanted as you look at the rule or our material, I think it'll make it a lot clearer. I apologize, the rule is long, but when you look at it, almost the entirety of the text is really about explaining the thought process and working with all the folks who commented on the rule in the public rulemaking. We got 2,000 comments. So where did we end up with this? So the first requirement that Congress had was application programming interfaces, APIs, and Congress put a very special twist on that to have those be without special effort. So that was the mandate. And so then what does without special effort mean? That was one big part of it. The second big part of it is a prohibition against information blocking. So Congress said the default assumption should be that patients get their information, no ifs, ands, or buts. So that is obviously a large issue in the past because for a variety of reasons, patients have not been fully empowered to get their information. So how did we in the rule deal with these two big requirements? Because that really answers, I think, what's in the rule. So the first requirement is application programming interface without special effort. And that works through our certification program. So we test for those APIs. And those APIs, of course, we have a great opportunity now because I think the technology has really made this robust interoperability possible in a way that if you look back, certainly 5 years, 10 years, it really wasn't there. So we're talking about RESTful APIs using the JSON, the JavaScript Object Notation Data Structure, FHIR, FHIR, Fast Healthcare Interoperability Resources for the healthcare terms. So that is what we're requiring to be tested in the certification program. It's a very important part. It's a very modern way. It's the way the app economy works, because the goal here is really to get patients their information on their smartphone, and to do that in a way that is not just here's your chart or here's your medical record on the smartphone form factor, but really to give patients their data in a computational way, to give patients what the sort of, I guess, more theoretical folks refer to as agency. That's a fancy way for saying patients should have control. Patients should be able to get apps in that allow them to manipulate their data to give patients benefits as the patients may choose. Certainly for the patients, all of this is absolutely optional. You do not, if you don't want to use smartphones, you don't want to get the data from the EMR of your provider, you don't have to. So those are that's the top level of the API role. An important part that is also there as we're advancing FHIR. This has been an activity that really goes back actually to the SMART grants in 2010 in terms of building out these standards and the interoperability, the technology, the implementation guides. What we want there is not just the smartphone, but also we have a provision in there with FHIR version 4 to do what we've called bulk FHIR population level data. So that is not a one patient, but it is something that providers can use and payers can use. All of that sits squarely under HIPAA, those types of transactions. But right now, if we've talked a lot about big data, a lot of talk about big data, but people forget there's actually no API to do big data, right? All those big data things you hear about are one-off custom queries. So as part of ONC standards work in the rule, our standards in the testing and the certification has that bulk FHIR so that people can actually do big data, modern analytics. Let's talk about the privacy and security here, obviously critical in the world we live in. So what we have on the patient side, the bulk is, of course, the same security as we have today. Those are between covered entity, business associates, contractual. Those are, very identical to any other electronic transmission between those types of parties today. For the patients and the app economy and that app world, apps patients choose, apps that have convinced patients that they have something to provide to the patient. There, what we're doing is we're using a secure protocol, OAuth 2, used by the banking. We are binding into that process the ability of the provider endpoints to inform patients that their data is now not covered by HIPAA and is fully owned by the patient, as opposed to being controlled by the provider, as it typically is, and to require the app to say what their privacy policies are. So that is part of that OAuth 2 transaction. So what we're aiming for here is a very informed public, very informed choices. The way we've built it in the rule, it's also enforceable by the Federal Trade Commission under deceptive business practices if the apps mislead the public. Also, there are about 20 states that have state causes for action here. So that is what we've done with privacy and security to really push that envelope with the regulatory powers that are in the Cures Act and that we have. So we've just covered the first topic, which are the modern APIs without special effort. The second big area Congress noticed is the issue of information blocking. This has been building up over a number of years, and Congress has noticed, well, we can say what we want or require what we want about having an API, but if there's not an obligation to move that data, those APIs really, are, as we say, empty. So what Congress said is, and it is the law as we speak today, that there shall not be information blocking. The Cures Act asked us, the Secretary, to come up with allowable exceptions. So we've grouped the exceptions around information blocking data flow. There's one class when providers don't have to share data. So if there are specific issues about privacy, security, harm, system uptime issues, then obviously it wouldn't be reasonable to share the data. I should point out, though, that those have to be very specific in the rule. You can't just say, the world's a dangerous place, I'm not going to share any data. You have to have very specific identifiable threats. The other part of information blocking is really the concept that with that, we've heard complaints that the fee structures absolutely prevent information blocking. So we have some requirements around fee structure. So for patients and their apps from providers, that information is part of the cost of care. For providers getting APIs from their EMR vendors, obviously the EMR vendors have to bill this, have expenses, so we allow for reasonable costs, including profit there, sort of costs reasonably incurred is the language that we have there to make this work. So what are the timelines of these two provisions? So for the timeline for information blocking, the first 6 months, there's no enforcement. As a practical matter, we're still coming up with the rules on the enforcement to begin with. So, it'll be longer than 6 months, but for sure, 6 months is a learning time for folks to just get aware of the rule. For the first 2 years, so from month 6 through month 24, the only data that needs to be shared is data in our US core data set for interoperability, the US CDI. After that, all data would potentially need to be shared. We've put in something that we're labeling content and manner. So those are some provisions on what content has to be shared. We just talked about the US CDI, so medications, allergies, problem list, clinical notes for the, up until month 24. And then the manner can be either negotiated with in a proprietary kind of way at a market rate, or by standards, or with just machine readable. So more details on that are in our various briefing documents. So that's the timeline on information blocking. For certification, we got a lot of feedback that folks wanted more time. So instead of having all information to be shared at 24 months, we have just the US core data for interoperability as an API requirement in the certification process. And so providers can have it at month 24 after the rule is in the Federal Register. Then another year later, Congress put in a provision on all data, so a data export. So that follows a year later. So I think those are some of the top level considerations in the rule. We thank everybody for their feedback. If you read the entire rule, you'll see we addressed and thought about every single point of feedback that we received. And we are very excited. We think this is something that is going to change the game for the American public. It's going to make healthcare, the computing around healthcare modern. I think it's going to give all kinds of empowerment to providers. I think as time rolls on, these APIs will take away a lot of provider burden. Working with CMS, we've already set in path of motion so that the documents, the notes actually reflect what went on in the patient as opposed to billing boilerplate. We're in earlier stages of working to address the whole prior authorization burden. And eventually, when these APIs are up and running, instead of having these very expensive one-off curated quality measures, we'll be able to use the entirety of the chart and the entirety of what providers do for patients as a way of assessing how to pay providers. The entire conversation of value is going to shift with a lot more data. So in summary, we're excited. It is something that empowers the American public in a way that they can shop for their care. We think that this sets in path a way to reduce a lot of burdens for providers. We've gotten a lot of feedback from EMR developers to make these rules work for them in terms of costs, market opportunities, and some of the specific technical issues like intellectual property protections. So with that, I think we have some time for questions.
Yep, thanks a lot, Don. This is very helpful. So so we'll go to the first question from Umar on the YouTube channel. To what extent does FHIR bulk data take into consideration the risk factor assessment models for pop health, which is more suited for specific ethnicities or backgrounds to form a reliable baseline?
Can you ask that question again? To what extent does the FHIR bulk model do what exactly?
Yeah, so essentially, how do you think it could be used to address baselines for different patient populations to calculate risk for those populations?
Right. Well, so the FHIR, the bulk model is really, what are the resources that you bring in, and ask yourself where we are doing some work. There's some work in the US CDI getting started on demographics. Obviously, there's more work to be done on what is called the social determinants of health. But the types of queries, it's not that prescribed, really. The types of queries are whatever the covered entities and business associates working, however, the covered entities, right? So doctors and hospitals. So to whatever extent they want to use this API, but it is really the provider's API. So it is, usable by them for whatever they want. We're doing this as a convenience to providers. So instead of having to pay for and sort through, one-off queries and a lot of custom programming work, they can use modern APIs. But what providers end up using that for is really their creativity. We're excited, as I mentioned, that we think it's going to allow a whole bunch of other ways of thinking in a modern big data type of way. The analytic powers that have helped almost every other industry have often been missing in healthcare, though we're very good at analysis, but it's been in controlled clinical trials rather than in these modern, more, if you will, amorphous data methods. Now that may be the opportunity, but it's ultimately it is controlled, owned, and only to be used by the covered entities, so doctors and hospitals. So what they do with it will be up to them.
Awesome. Thanks, Don. And then another question from ePatient Dave, who will also be on a panel later this afternoon. Great presentation. To be very clear, are visit notes, aka open notes, explicitly included in what providers will need to make available via API, with few, if any, exceptions?
Yes. So the US core data for interoperability includes clinical notes. So that is, it changed from the common clinical data set that we had in the past as a certification requirement. So it includes notes, that includes the classic clinical notes, diagnostic imaging notes. Obviously, the US CDI will advance over time. What is not in there now, but I think at some point as bandwidth increases, will be actual images.
Awesome. Another comment and question from John. So thanks for the specific timelines that decrease uncertainty, but are there other items expected to come out via the administrative rulemaking pejorative?
Well, so one thing that is in the works are what are the enforcement on information blocking. So for folks who are, I guess, in the weeds on the law, the 21st Century Cures Act, in that Title IV section, Congress identified 4 entities that are not allowed to do information blocking. So they are certified health IT developers, they are health information exchanges, health information networks. Those 3 have what in DC jargon are called CMP. You'll learn a lot of acronyms when you do this kind of a job. I always wonder what neurons are being lost for some useful information. But at any rate, CMP is civil and monetary penalties. So that rulemaking is still in the works. The Cures Act also, the 4th category is providers. And by the way, health information exchanges networks, we've merged into one. There's no way to distinguish them. So that's a single entity. For providers, the Cures Act has the secretary shall determine disincentives. So that is also a work. Again, the hope here really, and the design and the way we've written the entire language around, for example, allowable charges is not to penalize people, but really to sort of get the information to flow. And we hope that there's really, that folks embrace that openness for patients and embrace it as something that can provide better care, more connected care, really to connect with patients rather than here's some specific fine. So this will solve itself over time. Frankly, I think most of the, if you will, air quotes enforcement here is not going to be from the federal government and rulemaking and any of that type of stuff. It's going to be our public expectation that we have our data on our smartphone. You can't go anywhere without seeing everybody on their smartphone. It is our public expectation, our human right to have this information. I personally believe that is going to drive this in advance of any of this rulemaking. Yes, we've done the rulemaking, but I believe it is really, if you're a provider and really want to provide top-level care, which I think pretty much all providers do, because ultimately it's a very charitable human endeavor. I think in this modern era, that is part of communication. So that's the way I see this playing out. I don't know if that helps, but that's the way I think this is actually going to play out.
Yeah, that's very helpful. And Anish will be speaking soon after this, and we had asked him for some questions to help spur the conversation. So, he is.
All right. Well, if it's an Anish question, it starts with, "Are you going to promise that you do this?"
I think these are.
For those of you who know Anish,
friendly.
A big supporter of interoperability.
Yeah, of course. But obviously, these are very historic rules, and as you just mentioned, I mean, it's going to be a paradigm shift in the way that individuals deal with their medical data now that they can deal with all other data on their phones.
Well, deal with their medical care, really, even more than their data, really, because it really empowers you to totally rethink what care is.
Yeah, for sure. And there must have been some heated debates in the last few months. How much opposition do you anticipate now that the rules are final, and how do you think that's going to express itself?
Well, you never know what people necessarily will think. We've gotten a lot of support. Certainly, if you look at, if Twitter is an indication of anything, maybe it is, maybe it isn't. But we've certainly gotten a lot of support. You may have noticed all 6 of the prior national coordinators. So, 2 Republicans, 4 Democrats have strongly supported this process and have, in fact, laid the groundwork for what we announced this week. So, thanks to all of them for the multi-year, multi-stage process here. I think that what's going to happen here is, and this is, again, happening not just because of the rule. I think it's happening because of modernity, because of the ubiquity of computing, because of the power of networks, all things when I started my career, we had nothing of. But I think everybody who's in the business world, healthcare or not, is rethinking what these technologies mean about your interactions with your customers or your business partners, the B2C, B2B. All of those things people are rethinking. I think in healthcare, we've sort of been laggards. I think we've, been able to have enough sort of a regulatory cocoon, if you will, in this funny third-party reimbursement world that we live in that has sort of isolated us from the public and the consumer and what the public wants. But, make no mistake, the American public is quite unhappy with healthcare. They're demanding transparency about price and what they're getting, price and product, the way we shop online. So I think people are going to have to rethink their business models. People are starting to do that. And, I think we'll hear, it'll be an iterative process as people rethink that.
Awesome. So we have another question from Rebecca on our YouTube channel. So how do you see patient-reported outcomes fitting into the integration of electronic health information?
Yeah, so the patient-reported outcomes, obviously, as these APIs work, the APIs that we've done in this rule are read-only APIs, right? So getting information from the database underlying the doctor's or hospital's electronic medical record. It's a much bigger technical lift to do read-write APIs of any kind, whether it's patient data or some third-party data. There are a lot more issues about where you do it, what are the nature of the underlying function calls, because it's not just simply relying on a database driver. You have to get much deeper into architectural considerations, design considerations. There are gating issues on the volume of these requests, denial of service type of issues. So it's much more complicated, just baseline, if we're going to write in. So that's a work in progress. ONC's supporting some early research there. Obviously, a lot of consumer folks are working on this. I think beyond the technology that needs to be addressed on just the computer science of writing into these enterprise or business software components, the two other things that I think we have to address there is further work on standards. So what's the format of that? If it is just the PDF equivalent, loosely structured data provided for providers, that would just overwhelm providers. So I think we have to think about what are the data structures, what type of data feeds, what type of standards, and then think of, in the same way that I believe in the app economy, people are going to do software apps to interpret what is in a provider medical record. I think in the same way, there are going to be software apps to interpret the patient-generated data and give that back to the provider. I think it's going to need interpretation of both sides for, time reasons, clarity, completeness. So I think those computational problems will all need to be addressed to a greater or lesser extent before we see a lot of that. We absolutely will. I think it is part of what the ONC rule and the Cures Act, in fact, unleash, which is the ability to use our smartphone, not just as a little baby computer with a little baby screen in our pocket or our purse, but actually as a connection point to an entire Internet of Things, medical devices, whether it's test kits or glucometers or peak flow meters or heart rate monitors or blood pressure cuffs or digital scales. So I think the smartphone is not just a computing platform in and of itself, but is really the connection point for a totally different way of thinking about and engaging patients in care. Long answer, but it's pretty exciting. I think we're going to all be amazed by what we see here over the next 10, 15 years.
Yeah, I totally agree. This is going to unleash a lot more possibility than existed before. We have another question from Craig. Do the final rules clarify if public health programs such as immunization registries that collect health data and then share it qualify as HIEs or HINs and fall under the same information blocking requirements?
That's a specific technical question. I don't have that immediate answer. I know there's some provisions, and part of that also is our work with the Trust Exchange Framework Common Agreement, because a lot of that rolls over into that. But I know we're in the process of crafting some specific considerations for public health agencies.
Okay, cool. And I think we'll ask one more question. So
Sure.
There seems to be a good deal of work on the implementation phase. There might be a few areas that you guys are looking for private sector participation. One is, privacy. Another is EHIs, and another is, bulk data. How do you think that you would spur the, private sector to collaborate with not only the federal government, but also the players that have to implement these rules?
Yeah. Well, look, we're a free market administration. This is an administration, and certainly I personally are folks who believe in the private sector and consumer sovereignty. So the entire rule is really geared around letting private parties, build apps, letting patients be in control of their data, and not having sort of, other than this, I know that sounds a little bit internally inconsistent, but really opening this up to the broader control of the American public. And we absolutely assume essentially all of this will be done by the private sector. An interesting example of that, a great example, is the Da Vinci Project, where a number of the payers and providers are getting together to start working with the bulk data and some affiliated things on prior auth. So we see all of these things as putting the private sector, whether that are the patients, the providers, the payers, entrepreneurs, putting them in charge of what is offered here. That's the entire scope of design, really. So, yeah.
Okay, awesome. Well, Don, we understand that you have to be somewhere sharp at 12:30, so we're going to let you go. But thank you very much for taking out time from your busy schedule to come here and talk to the community. We really appreciate it.
Yep. Thanks for doing this, and I want to personally thank everybody involved in the public comment process. We hope we've done you right in all of this, and encourage everybody to think about the great opportunities here. It's an exciting time to be thinking about what modern computing can do for healthcare. So thank you, Ricky. Appreciate it.
Yep. Bye-bye.